Hello everyone. My name is Dr.Sanjith Saseedharan. I am the teacher and head of the Department of Critical Care at the SL Raheja Hospital, Fortis Associated, Mumbai, Maharashtra. I've got a keen interest in mechanical ventilation, hemodynamics, and nutrition. To sum it all, I believe in personalized medicine. I'm an anesthetist by profession, but doing critical care since the last 25 odd years. I do have a couple of publications, and you're all welcome to look at the website drsanjith.com for details regarding those. So without much ado, I think probably we should just go ahead and take this webcast on indirect calorimetry. Well, today's topic is all about indirect calorimetry, and to go across in this topic, I'd probably talk about why we should be using indirect calorimetry, why we should probably not predict the energy expenditure or requirements for a patient, and I'll make it so easy for you to understand that doing this is not at all difficult. And then I'll back it up with a little bit of data that comes from the Indian scenario, which is extremely poor on data management and research. Critical illness is a very, very all-inclusive kind of status or disease, you could call it, where it has got a response. The characteristic of every critically ill patient remains the same, but it is the intensity that actually changes. And as a summation of all of this, this relates to a drop in the protein content of the body, visibly by looking at muscle wasting and nitrogen loss. This also causes some metabolic abnormalities, especially with the glucose oxidation pathway, specifically the conversion of pyruvate to acetyl coenzyme A. It is this rate limiting step that causes this problem, which prevents glucose from getting oxidized. So we might wonder, why not just give insulin? Well, that doesn't seem to be the answer, because giving insulin will actually cause reduced lipolysis, enhanced lipogenesis, anaerobic glycolysis, and the production of lactic acid. So it's not so easy, just give insulin and the glucose will probably be controlled. In fact, the answer would be, let us give adequate glucose, adequate energy, and that's probably the answer for this difficult question. Well, we always thought that all these illnesses had two phases, one being the systemic inflammatory response and the second being the counter anti-inflammatory response syndrome, immunity that comes in and kicks in later. But now we know that it doesn't work that way. They both come together. There is a reduced adaptive innate immunity and a dysregulated host response that is generally seen in these patients, very similar to something called as a genomic storm. And I think that's what causes all the problems that we face in critically ill patients, specifically inflammatory and neuroendocrine. And that's how our patients go really, really bad. That's the response that we're worried about. So what? What's about this critical illness? It's like a monster. It's really like a monster. Now, there was this study that was done by Lindsay Plank quite a while back. What they did was they looked at approximately 12 patients. Each of those patients were post-perforative peritonitis, operated. They were managed by 5 intensive care doctors who were specialized and had keen interest in nutrition. They ensured that all these patients were monitored by resting energy expenditure via indirect calorimetry, and also they looked at predictive equations. They fed all these patients at 1.2 times the resting energy expenditure with a solution called osmolite, and they ensured that they monitored these patients very regularly. All of these patients were at a Apache score of around 20-22, and most of them had an average mean survival stay of 29 days. So they were in the ICU or the hospital for a median stay of around 29 days. So they followed up all these patients. So what did they see? So let's see what it looks like. So it looks like these black dots are the ones that were seen by resting energy expenditure, monitored by indirect calorimetry, and these white open circles are those that were the predicted equations. So if you look at it, there was a big disparity between that was measured versus that was estimated. So there comes the discrepancy, and that's what exactly happened in my hospital also. I mean, these are equations that have, it just sees that there's a huge amount of variation of indirect calorimetry with respect to predictive equations. And what is also very interesting is that at somewhere around 9th or 10th day, there is a peak in the resting energy expenditure seen in the graph that I've just now shown. And this is exactly what we see in our hospital also. This is the graph of a patient that was in the ICU for quite a period of time. And somewhere around 8th or 9th day, we see him peaking on the resting energy expenditure. So this is something that's occurring. So the orange line is the energy expenditure calculated based on indirect calorimetry, and the blue line is the predictive equations based on SPEN guidelines. So it's obvious that there's a huge variation on the amount of energy required for these patients. And what is more interesting is that this resting energy expenditure remains elevated for almost 24 to 25 days. That's a very, very long time when the patient is so catabolic that he requires good nutrition for almost 21 to 24 days. Well, let's look at the other graph. Now, the black dots that we see is the pre-albumin, and if you see, it comes down to a very low amount up to the time of 21 days. And when you look at transferrin, the transferrin slowly creep up, but still becomes near normal and not really normal. This indicates that it is very difficult to catch up to an extent of almost 21 days. So the catabolic response is so bad that it remains for a long period of time, and anabolism doesn't seem to get back quickly. So there is something wrong with the way critical illness plays out, and we don't know how it is done, but this is what occurs. So it's all the more reason that we should be probably giving what the patient requires and not what we feel or what is a rule or what is a predictive equation that we think of. Now, we followed up these patients. What we found out was the body weight went down from day 0 to 79 to somewhere around 66. That's a huge loss of body weight, isn't it? These are the same 12 patients that were followed up, and on day 21, they seem to have shrunken. And what really got lost was the fat-free mass. It wasn't really the fat, it was a fat-free mass. Well, if you followed them up, there was a drop in the total body proteins for certain. There was a drop in visceral proteins as well as skeletal proteins, but the maximum drop that was seen at 10th day, with the skeletal muscle protein being more dropped than the visceral proteins. So it's very obvious that if a patient goes through any critical period of illness, there is going to be a drop of skeletal muscle protein, and that is going to drop the body weight by a tremendously important amount. Almost half kilogram body weight can be lost per day in such patients who are extremely hypercatabolic. Now, any patient that comes, or all of the human beings are fighting for survival, and we are all at a phase called as homeostasis, and this fight for survival is called as homeostasis. Now, when the patient gets a little bit ill or is getting stressed up a little bit, they go to a new phase called as allostasis. And this allostasis is the new normal. Things are still okay. That's how our body responds. Now, let's take the example of this case. So there was a stressor, there was an allostatic load that came in, and it's at this point that the new normal was achieved. Now, let's take this patient somewhere around 5th or 6th day post anesthesia, post critical care, and now he's about to get out of the ICU. And at this phase, we have another stressor coming in. That another stressor will then lead to problems: morbidity, mortality, increased length of stay, critical illness, polyneuropathy, myopathy. And this allostatic overload seems to be the underfeeding and the overfeeding that we subject these patients to. And this per se is known to cause increased mortality, nosocomial infections, length of stay, bed sores, length of ventilator. All this may have a problem over here. Even after knowing so much, worldwide we seem to be feeding our patients very, very low. I mean, there are studies all over the world talking about 40% and 68% and 51.6%, and even data from our hospital, from the hospital where I work, shows gross underfeeding. proteins as well as calories. So I don't think we're doing a great job on feeding our patients for certain, and we are doing it and we are creating iatrogenic problems is what it looks like. Okay, so coming to the point of whether we can predict which patient actually needs more or specialized nutrition, that itself also is a very difficult problem. If you look at various scores, the MUST score, the SGA score, the MNA, the Nutric, the NRS, it really doesn't make us understand whether this patient requires X amount of calories or requires X plus 5 amount of calories. And that's the problem. They don't even agree with each other. They're not so good. And that is the reason that predicting which patients will require more amount of support is also not in our domain. So we cannot predict which patient, and we cannot predict how much this patient will require. Well, this was a study that was done from the Iskak-Rabin Institute, where Oren Zussman and Professor Priya Singer went ahead and looked at 1,171 patients who were monitored by indirect calorimetry and by the Harris-Benedict equation. They were a group of patients who were mixed medical patients, trauma patients, respiratory tract problem patients, cardiac patients, and all of them were definitely ill with a median Apache score of somewhere around 22. They monitored them via the resting energy expenditure, that's the average that we see over there, and they also looked at the Harris-Benedict equation in these patients. And what did they find out? They found out a beautiful relation. The relation looked like this. That means if you were to deliver the resting energy expenditure, about 70% of the resting energy expenditure, the mortality seems to be going down. And when you start feeding them more than 70% of the measured resting energy expenditure, it seems like the mortality just goes up. That means 70% seems to be the golden number, and I think we should target 70% of the resting energy expenditure in most of our patients, provided we know the exact resting energy expenditure. This relationship did not exist with proteins. The more you fed the proteins, the better the patient became and lesser the mortality. This was very obvious, and when they adjusted them for various variables, this relationship of 70% still persisted, clearly indicating that we need to feed optimally, and the optimum level seems to be 70% of the resting energy expenditure, shown again by the Kaplan-Meier survivor graphs, where if you fed the patient around 70%, they survived more. If you fed them more than 70%, they survived less. And if you fed them much more than that, they survived even more lesser. And what happened when you fed them via Harris-Benedict equation? It's very obvious that the amount that you fed was much, much higher. Much, much higher. This is what it looks like. Definitely, this is not the way to do it. When Vanderbilt University looked at another cohort of patients, they also kind of simulated the same results. What they did find out was in that group of critically ill patients, they divided them to septic, non-septic patients. Around 800 odd patients were looked at. They measured the resting energy expenditure, and they estimated the predictive equations. And what they found out was when there was no energy deficit, the mortality was high. When it was underfed, the mortality was again high. It was only when they fed near about 70 to 80% that the mortality did not change. Going on to say very clearly that measured energy expenditure should be known, and when you actually estimated them, you actually overdid it many of the times, is what it looks like. This means we really cannot assume what the energy expenditure was, nor can we predict what it should be. If you assume, this is what happens. The red lines and the blue lines are indirect calorimetry readings versus the one that was assumed. For example, somebody just came and said, let's give us 2,000 calories, a rule of thumb. They assumed, they thought, they believed that this could be the amount of energy that was required, but this was definitely not the way it was to be done. You can see the graph that there was really no level of agreement to any of those, and this remained when you even predicted them by any kind of equation, let it be the ISPEN guidelines or the Harris-Benedict or the Ayrton-Jones. So we then started predicting that maybe that if the length of stay is high in the ICU, these patients are going to be more sicker, they're going to be more catabolic, and that's probably the reason that these patients may require higher energy. But let me tell you what happens. This is a graph of patients versus the indirect calorimetry of these patients that were measured. So now look at those patients that remained at 6 days of ICU stay. There was a difference of indirect calorimetry readings of almost 600 to 700 kilocalories, which is definitely very, very high. Now, when you look at 3 days patients, look at these are patients of 3 days each. Again, you see that there's a huge difference in the indirect calorimetry readings, very clearly evident by this graph, showing that it cannot be assumed by just looking at length of stay, and thus calorie requirements cannot be judged by the expected length of stay in any way. So people started saying, okay, let's look at it by severity. But it's very obvious here too that even by looking at severity, the resting energy expenditure cannot be assumed for certain. That means stress or severity demand has got huge amount of changes in calorie requirements, which just cannot be estimated, and it is not in a straight line for certain. Let alone diseases. Various diseases have got different kinds of resting expenditure. Look at this in various diseases: diabetes, LV failure, AKI, sepsis, and with severity, it's all over the place. You just can't understand whether which patient requires how much calories, which patient requires how much calories is a $1 million question that can be answered only and only when it is measured. Even in a single disease, if you look at it, this is sepsis. Look at some patients who require so high, whereas some other patients require so low, and this is what is seen in most of the diseases, and that is why personalized medicine is something that is the way to go. In fact, look at this one patient with sepsis. When you used indirect calorimetry and when you did not use indirect calorimetry and you assumed a certain calorie requirements, there was definitely no overlap between them. In fact, towards the end of the admission, there was huge disparity between the calories required versus the calories that were actually provided when you assumed them to be a certain amount by rule of thumb. This means to say that each patient is very, very different. And that's why I believe that those who have knowledge should not predict, and those who predict probably don't have any knowledge. And that's the reason predictive equations should be not used when we are using, when we have critically ill patients who are dynamic, who needs a right kind of energy expenditure reading that comes out after measurement only. So I think I put the point further that resting energy expenditure is disease specific, is condition specific, and it cannot be seen in a single patient. It varies during the course of disease very, very unpredictably, and it cannot be based on height and weight alone. And that is the reason that this statement holds so much significance, that one size does not fit all. In fact, Edward Abrahams, who's the president of the Personalized Medicine Coalition, said, one day patients will say, I'm not an average patient. I am who I am. You need to understand who I am before you prescribe whatever treatment you plan to prescribe. So what? So it's important that we don't wait. If it's just not right, we should move on. And to measure seems to be the key. We have to measure what we are giving our patients. And there have been various ways how we measured: direct calorimetry, heart rate based estimation, double label water, Medgem-like devices, bioelectrical impedance, first beat by beat method, and what we are going to discuss today is indirect calorimetry, a great method. Many monitors in the market which are helping us to do this indirect calorimetry. But I think even after so much advances that have come into technology, it is still, you feel so sad to understand that there are very few people all over the world who are actually using indirect calorimetry. And I think there are a couple of reasons for this. Two reasons that are non-modifiable are an inertia to change and attitudes, and that can't change by just a webcast. You need to understand this, you need to change behavior. That's not the matter of this webcast. But if you feel that it was complex, I'll probably tell you it's not complex. If you thought it was costly, it's really not that. And if you thought it doesn't do anything, I'll show you evidence that it does a lot of things. Well, what is indirect calorimetry? Every cell in our body breathes. When it breathes, it takes out carbon dioxide, it takes in oxygen. If you were to monitor the volumes of carbon dioxide that is being expelled out, and if you were to monitor the volume of oxygen being taken inside, we could put it into this modified Weyer's equation, where the VO2 could be now found out, the VCO2 or the oxygen or the carbon dioxide that has been coming out, volumes can be found out. We could calculate the resting energy expenditure. Isn't that so simple? Well, there are different kinds of devices that have done this. They can be done breath by breath, and the earlier devices had mixing chambers. So there are different mechanisms of finding out, doing this equation. And if you look at this, this is a patient that is lying in my ICU. If you would find out, this is a patient in prone position. So the patient over here, the indirect calorimeter they can find out is close to the ventilator down there. It is that small box that lies over there. That is the indirect calorimetry device that we use in my institute, which works by just a plug in and a plug out. You just plug in and you're ready to use the indirect calorimetry very soon. There are certain reasons why you will probably have to wait, or certain caveats have to be followed, and I'll come to that. So in short, it is definitely not complex. It is simple, and it is really not very expensive compared to the length of stay that it can stave off. So this resting energy expenditure can be used by can be found out by simple devices, provided we follow a few caveats. The few caveats are, you need to wait for the device to warm up a little bit. It takes somewhere around 30 minutes to 45 minutes for the device to warm up. The calibration is usually factory calibrated, and you don't need to calibrate it again and again. There should be no leaks in the circuit. Even a small leak in the circuit will cause a problem, and your readings may not be right. You can't use FiO2s usually more than 0.7. That's because of the equation. If the FiO2 is more than 0.6, it is prone to errors. So it's not advisable to use or measure resting energy expenditure when the FiO2 is more than 0.6. There should not be too much of oxygen fluctuations, and that is generally taken care of by pressure regulators on the back of ventilators. There should not be the use of nitric oxide. You should not play with the ventilator when the resting energy expenditure is being measured. You should allow it to wait for at least 2 hours without any changes, so that you get a steady state with very low variation in carbon dioxide and oxygen, so that the respiratory quotient and VCO2 and VO2 can be stable, a period of stability. You cannot have too many alterations in noradrenaline and adrenaline, inotropes and vasopressors when we are monitoring resting energy expenditure, and hence these patients should be reasonably stable before we actually monitor resting energy expenditure, and the temperature should be stable for at least 2 hours. You cannot monitor it if the temperature is very unstable, and high peeps are known to interfere with the management to an extent that if the peep is more than 12, the resting energy expenditure may not be right, and it is not advisable to follow the resting energy expenditure when the peep is more than 12. A recent paper that was done in 2019, published in the JTAC, actually showed a clear relationship of the improvement in morbidity and length of stay when indirect calorimetry was used. This is data that comes from a single patient from my hospital. This is a 40-something-year-old lady who presented to us with on antipsychotic medications, and mind you, antipsychotic medications are known to alter resting energy expenditure. So this patient was with anorexia because of a psychiatric problem, and she was subjected to a very small amount of feeding so that we prevented refeeding. But what happened surprisingly was, after 10 days, we were unable to wean this patient. So we were figuring out why this patient was not getting weaned off. We were giving her a small amount of calories which were predicted at that moment. That is when we decided to use indirect calorimetry. And the moment we started using indirect calorimetry, we just realized that we were feeding her for more than almost 600, 700 in excess. And when we came down on that, within a span of around 3 to 4 days, we were able to wean off this patient. Now, why did this occur? This was not evident on the EtCO2. This was evident very clearly by the VCO2. The alveolar ventilation did go down when we fed her well. She passed all the weaning predictors and extubation predictors, and thus got successfully extubated. So this is a clear-cut indication that indirect calorimetry can do more than what we thought. This is a study that has recently been presented as a poster in one of the national congresses in India. We looked at around 166 patients and we decided subgroups of Apache between 5 and 14, 15 and 23, and 24 and above. And we looked at historical controls and comparing data that came out from indirect calorimetry to historical controls. And what did we find out? Among all these patients, we did find out that there was no change in mortality for certain, but we did find out that there was a significant drop in the length of stay of patients who were in the ICU when we used indirect calorimetry, to the tune of almost 1.5 days. That's a big number of days that did come down when we used indirect calorimetry, and this was very, very significant in those patients who are at risk for malnutrition by any of the scores, let it be NRS, let it be Nutric, or let it be SGA. So it's very clearly evident that it does do something, at least in this database of around 162 patients, where we clearly indicated that it dropped the length of stay by almost 1.5 days, and 1.5 days is definitely a large amount of cost savings for this patient. So I would not agree to the fact that it doesn't do anything. Now that I've shown you, it does do a lot of things in these patients, and thus I think indirect calorimetry is the way to go. You must understand that no single monitoring can affect outcome in a big way unless there is a physiological state that can be altered with an intervention. So it cannot be proven for certain that if you use indirect calorimetry, mortality will change, because the intervention that we use, the food that we use, we're not very certain whether those foods will probably get assimilated, get absorbed, and get into the body. But it is as simple as this: if you do not monitor, you'll probably be doing more wrong things than otherwise, and that's very, very important. Not only that, indirect calorimetry also gives us an estimate of the physiological state of the patient by looking at the VCO2, VO2, and the respiratory quotient, helping us to tailor our nutrition, tailor our management, including our hemodynamics and our patient management. It does make a big difference if you understand indirect calorimetry very well. Needless to say, we have 4 Ds in management. We need to understand the drug, the type of feeding that we are going to give for indirect calorimetry to work very well. We need to understand how much calories we need to provide, and this can be done only and only with indirect calorimetry. We need to understand the duration as to how long we should be feeding them. That will be given by an estimate of the resting energy expenditure also. And we need to de-escalate this food item at certain times, and this is again we would get an idea by looking at indirect calorimetry. And that's the reason that the ESPEN guidelines goes on to say that in critically ill mechanically ventilated patients, energy expenditure should be determined by using indirect calorimetry, and it is not a good idea to use predictive equations for certain. That's the level of agreement that we have, 82% agreement, saying that it is better than predictive equation for certain. The Aspen guidelines also toes the same line by saying we suggest that indirect calorimetry be used to determine energy requirements when available and in the absence of variables that affect the accuracy of measurement. So it's very certain that indirect calorimetry is the gold standard. Indirect calorimetry has become easier to perform. Predictive equations are not great at all. Guidelines and experts definitely love it, and we all need it, and definitely I can't do without it. Thank you very much. Thank you very much. So let's answer some questions. So there's a question that comes from Institute of Liver and Biliary Sciences in New Delhi, and the question says, our experience in critically decompensated, critically ill, ventilated patients with liver cirrhosis is that they have typically low resting energy expenditure measured by IC compared to the recommended 35 to 40 kilocalories per kilogram body weight. So are we overfeeding, or should we feed as per indirect calorimetry? What, according to you, is the probable cause of this low resting energy expenditure? Very, very good question, and if you look at resting energy expenditure, when you see very low resting energy expenditures, that means your body is kind of a condition where it's in a condition where the resting energy expenditure is very, very low because of the fact that he's kind of very, very sick. So the extremes of resting energy are very high and very low, means that these patients are the sick kind of individuals. The resting energy expenditure also seems to go very, very low when the patient is sedated, when the patient is ventilated and deeply sedated, when the patient is sedated, deeply ventilated and in hypothermia along with paralysis, these patients' resting energy expenditure along with hypothermia go very, very low. What you are getting from an indirect calorimetry, as long as the various parameters are right. For example, if your respiratory quotient is somewhere around 0.8 to 1 and your variation of carbon dioxide and oxygen are well regulated within the less than 5% range, what you're seeing is what your patient probably needs. That's not the total amount. You probably need somewhere around 25 to 30% less than what you're seeing. In fact, if you're going to follow 35 to 40 kilocalorie per kilogram body weight, you are definitely overfeeding your patients, and that's not the way to go for certain. So we should feed by indirect calorimetry because this is the only way this can be assessed. In fact, if you were to actually feed them at 35 to 40 kilocalories, these patients probably may not fare well, and that's the problem. When we are in a multidisciplinary meeting, you have hepatologists, gastroenterologists, intensive care doctors, and all of them have got varying ideas. But remember, the right idea is indirect calorimetry, and there is no other way you can understand kilocalories that we have to feed. Well, so there is another question that says, sir, there is a new product in the market which can find out the amount of proteins the person needs. What do you think about that? Whatever product comes inside, proteins are not something that we measure by indirect calorimetry. Moreover, it is also important for us to understand that even if you know the amount of proteins that are going on inside, even if you know the number of calories that are going inside, it is very difficult to know whether the body is taking those proteins, assimilating those proteins, and incorporating those proteins in the muscle mass. So it's not an easy task to say that I know X amount of proteins is required. Really speaking, proteins, if you are keeping it in the range of 1 to 1.5 grams per kilogram, it does a world of good, is what it is very clear in all the studies, that if you feed them more proteins, they are supposed to do better with respect to morbidity and mortality. And in fact, the only place where proteins may not be used at the range of 1.5 is probably grade 3 and grade 4 hepatic encephalopathy. Well, there's a question that says, what is your experience with respect to patient outcome based on a IC guided feeding protocol? Well, we have completed 2 trials now. One of the trial is awaiting publication. It has already been accepted. So we did study around 160 patients, and it just seemed to have some kind of relationship in improving or reducing the length of stay. We can't have endpoints of mortality, and we cannot say indirect calorimetry will change mortality in any way. It doesn't seem to occur that way, but it will definitely reduce soft endpoints like length of stay, length on the ventilator, and probably reduce weight loss if you were to feed them the right way. They will get off the bed. It is not a single monitor or a single calorimeter that will change mortality. It is impossible to do that. To make nutrition change mortality, nutrition change hard endpoints like death, you will need to keep this patient monitored for a period of around 3 months, and that is not something that we would do. We would probably use it for a period of around 10 to 15 days, and subsequently what happens at home is a very different story. But definitely, even in the short term, for 10 to 15 days, it does seem to cause help us to get the patient off the ventilator quicker. It helps to get the patient mobilized quicker, and it also reduces the length of stay for certain. Well, so There's another question asking what is the difference between direct and indirect calorimetry. Well, direct calorimetry is what you see when there's a room, an insulated room that is a large room which has a thermal jacket and a water and an exhaust and a generator and things like that, and you sit in that room, you sleep in that room, you eat in that room, and whatever heat is expended by our body is now judged and monitored, and that heat in kilojoules is then your resting energy expended. This is direct calorimetry. What we're doing here is indirect calorimetry. We are using pulmonary functions, we are using respiratory functions, we are looking at VCO2, VO2. That means indirectly, by looking at volume of carbon dioxide expended and volume of oxygen taken in, we are actually putting them into a Weyer's equation and indirectly finding out the energy expenditure. That's why this is called as indirect calorimetry, whereas direct calorimetry is very, very different from that. All right. The next question that comes is, does indirect calorimetry data help us calculate cumulative negative energy balance, or does it change with feeding? Well, indirect calorimetry meter will give you the actual calories that are required, and definitely if you were to use it, we will know that it is the resting energy expenditure for the previous 24 to 48 hours. It will not tell you 7 days in the past. It cannot tell you that this patient is malnourished. It can't tell you that. It cannot tell you that 10 days back what was his negative energy balance. It will only tell you for the next 24 to 48 hours, this is the kind of energy expenditure that this patient is having, and this is what you probably need to do it. And that's the reason that we repeat indirect calorimetry readings once in 2 to 3 days. It is not recommended to do it every day. It doesn't make any difference, but in 2 to 3 days is what is the recommended for measuring indirect calorimetry. So it doesn't tell you long-term cumulative deficits. In fact, if you want to understand whether there has been cumulatively a reduction, the only way you can do that is by actually doing an ultrasound. And there are devices like the muscle scan in which you look at the ultrasound, look at the fat density, look at the quality of the muscle, and with that you will probably understand that these muscles are already kind of in an injured or in a protein deficient state, and that's why these patients need to be tended to much better than the rest. Right, I think so. Despite this one question that comes in, despite feeding 80 to 100% energy intake, respiratory quotient remains low, 0.7 to 0.8. Okay, so good question. So you are feeding the energy intake, but what's actually contributing to the energy is actually is what your respiratory quotient is telling you. So if you were feeding at 0.7, most probably the entire expenditure is not very well balanced with carbohydrate, fats and proteins. So it does mean that one of the components are much, much higher, and that's why a respiratory quotient is towards 0.7. If it is toward the extreme of 1 and plus, there again you have a balance with respect to the fat, since probably you are feeding the patient too much fat. So the balance of carbohydrate, proteins and fats would change the respiratory quotient for certain. And if it is between if it is less than 0.7, that's your problem. Your problem is the balance. So yes, that balance is what is important. So there's another very important question that's coming in. Will pulmonary shunting affect indirect calorimetry results? So if your patient is on a very high PEEP, I mean you're giving a patient PEEPs of upwards of 10, upwards of 12, and you are on a very high respiratory rate. So there are errors that come up with indirect calorimetry. There are errors that come in, and those errors are something that the monitor cannot tell you. So in short, it has not been tested in patients with PEEP more than 12, and we don't have those fine calorimeters that can pick up these small leaks that occur. In fact, those patients who have got very high cuff pressures, they may leak through their cuff when they are on an endotracheal tube, and that itself might lead to erroneous measurements. Per se, a pulmonary shunting is not being studied in indirect calorimetry, and so clear-cut cannot be said that in pulmonary shunting, this degree of pulmonary shunting, indirect calorimetry will not work. But there I think we need trials to understand whether that will change. But it does seem logical to say that if there is excessive pulmonary shunting, the VCO2 and VO2 will not probably be the right VCO2 and VO2s, and we may not get the right readings.